Good evening. May I introduce you to QASM Connects. My name is John North and I'm the Clinical Director of Queensland Audit of Surgical Mortality. This is the first in our webinar series for 2021. I'd invite you as surgeons to consider presenting to us your personal platform that you may consider worth sharing, or perhaps you have an insight that you may wish to enlighten us about in a specific arena. Anything that will aid in our safe, high quality care delivery to patients would be very acceptable. Tonight in QASM Connects, Dr. David Grosser will present Popliteal vein compression syndrome. I'll introduce him in a moment. I invite you at the end of the presentation to email questions and we will attempt to answer them with David live in the studio. Let me introduce him now. Dr. David Grosser is a Fellow of the Royal Australasian College of Surgeons and a Fellow of the Royal College of Surgeons of England. His current position is as Senior Vascular Consultant at the Gold Coast. He's based at the Gold Coast Private Hospital and has a very active practice involving venous surgery problems, endovascular surgery, and standard vascular surgery procedures. Dr. Grosser's special interests include varicose surgery and ablation, vein sclerotherapy, carotid surgery and stents, aortic aneurysms and aortic dissections, femoral stents and stent grafts, interventional radiology, advanced endovascular intervention, minimally invasive procedures, and in particular venous thrombosis and clotting problems. We look forward, David, to your presentation tonight, and we will try to answer those questions that are emailed to us after you've finished. Thank you.
At present, the most significant cause that is given for deep vein thrombosis and pulmonary embolus, and also applied to the most significant risk of recurrence, is idiopathic, which means that the doctors claim that they don't have any idea. The information I'm about to present has been around for a little while, but it really overturns this idea, and in fact it brings us back to the possibility that the cause is really iatrogenic. In other words, it's the fault of the doctors, because it relates to the positioning of patients and how they are managed not only in the operating theatre but also in ICU, in the wards, in recovery, and particularly after they are discharged home from hospital. But it also occurs in other areas where patients or individuals take up positions where they're sitting with the legs out in extension. The current consensus is that in the extended knee position, the veins in the leg should be open without impedance and have maximal flow. The first graphic demonstrates the concept we're about to present, which is that the main cause of deep vein thrombosis and pulmonary embolus is due to the condition that we have named the Popliteal vein compression syndrome. All my medical experience, both as a student at Sydney University, then as a trainee at the Prince of Wales and Prince Henry hospitals, and then overseas, and eventually into consultants' surgical practice. All throughout this time, the major cause of the morbidity and mortality associated with this serious problem has been flicked off to idiopathic. A huge amount of money has been spent on the investigations. We were even doing radioactive fibrinogen studies years and years ago, trying to find out where the clots would initially establish, but none of these studies and none of the other millions and probably billions of dollars around the world have really given any significant insight into this formidable problem, except that two of the three major principal Virchow's triad factors have really been excluded. Trauma and damage to the vessel wall, and both the hematological problems, those in the blood, except for cancer patients, have really been excluded as major causes. So this leaves blood flow as the most likely problem. But in trying to assess individuals and then the whole group of people with this problem, there's been no significant understanding of why the blood might be limited at any particular area in the leg, particularly with the legs out extended. It's always been considered that lack of movement is a significant problem, and I'd agree with our knowledge that lack of movement is a significant problem, but particularly if the legs are extended. So blood flow being limited seems to be the major problem, and after talking to Dr. David Huber many years ago, following his paper on occlusion of the popliteal vein in the operating theatre with the legs out extended, basically in the hyperextension position because of the silastic pads beneath the heel, we decided to look for other ways that this might occur, and in our ultrasound lab we decided to look for changes in every venous patient who came through for examination. In general, this was a lot of varicose veins, but people did turn up after DVT and they became part of the collection. This huge body of data from our lab has demonstrated that the group incidence in these venous patients is over 30%.
Is that okay?
Yep, sure.
Just bend the knee a little. And now straighten the knee. It's a bit hard to breathe. Just sort of wait for the knee to relax.
That is, the vessel shuts down, completely occludes, and there's a significant correlation with patients who have presented with DVT and pulmonary embolus. This means that for a significant part of our population, all that's necessary for them to do to develop a DVT is to sit or recline with their legs elevated in extension at the knee for long enough, and that seems to be at least 4 hours, and it's quite possible for them to end up with a significant deep vein thrombosis, and that can occur both below the blockage and obviously above the blockage. We have called this the Popliteal vein compression syndrome, defining it with a name and basing it as an entity so that it will be properly recognized as a really significant problem that needs to be managed carefully if we're going to reduce the cause of deep vein thrombosis and pulmonary embolus in all of humanity. This finding has been defined by us with the duplex ultrasound carried out in the sitting position with the leg flexed at the hip at approximately 90 degrees, with the knee able to be slightly flexed but then fully extended, and the ultrasound demonstrates the vein being completely cut off in the patients with this problem. We have confirmed it with venous angiography in occasional patients where it's been necessary to consider operative intervention to alleviate chronic compression, particularly in individuals that have it both standing and when they're recumbent. It's much less frequent in individuals standing, but it sometimes can be suspected when they are first visualized if they have severe stasis changes around the ankle and stand with hyperextension at the knee joint. I first formally reported this discovery in a lecture to the Royal Australasian College of Surgeons, combined with the Royal College of Surgeons in Brisbane in a meeting at 2016, and I had given many more informal talks and lectures in the years prior to this. The inertia to understanding, despite evidence, is common in medicine, and the consensus demands that the straight leg offers the maximum venous flow really made it very difficult to get significant support for this idea. The data that we collected showing at least 30% incidence of this popliteal compression syndrome was really supported by previous findings published by Huber and Matzo, but in slightly different circumstances. So reiterating, what we've shown is that the common position advocated for rest and recovery is highly dangerous and is a major risk factor for DVT and pulmonary embolus, and as yet there is no other problem or cause that has been discovered that would challenge it other than idiopathic. We have evidence of a risk that will block major venous flow in the leg, and if patients remain for a prolonged time like this, a resulting clot is highly likely. We've demonstrated that the recumbent sitting positions that patients are nursed in the ICU, the wards, the rehab, and the advice the patients are given on discharge, often to rest with the legs up, interpreted to mean with the legs straight, is the most likely cause of deep vein thrombosis and all the other problems associated with it. And it is our, and in fact your responsibility, to start making changes to the way that we look after our patients if we're going to try and influence the long-term problem that we face with the clotting abnormality of DVT and pulmonary embolus. David Huber, in his paper years ago, demonstrated that at least 40% of surgical patients in the standard supine surgical position with silastic Achilles heel support to prevent pressure effects on the heels is associated with complete popliteal vein occlusion at the knee. It would seem that this should have been accepted as a major breakthrough in the possible cause of DVT in the operating theatre. But in the years that have passed since David's work, there's been little change other than in areas that both he and I have had some influence over. in the management of our patients who are looked after with knee flexion managed either with his device or just with pillows at the back of the calf and a little external rotation, which basically resolves the problem. We should be able to bring about a major change in DVT and the incidence of pulmonary embolus by keeping our patients' knees slightly bent when they are immobile. Our new hospital beds are built with adjustable flexion at the knees, but this has to be used, and without education, the staff, I find, tend to ignore it. Elsewhere, we tend to use pillows under the calf with a little external rotation, as this tends to take the pressure off of the vessels in the upper calf. And it does prevent the compression of the main vein that occurs in extension, which, as you will see as we go through the duplex studies, this is related to the tightening and tension effect in the gastrocnemius muscles, and they basically come in and crush the vein and sometimes crush the sciatic nerve as well. But we found in patients that have this finding, they become uncomfortable and tend to move away from having the vein obstructed fairly quickly. To prevent DVT, scuds work well, but there is efficiency is reduced if the knees are allowed to remain in the typical extended position. And this will only affect the 30 to 40% that have popliteal vein compression syndrome. All current prophylaxis measures should generally be used to prevent DVT also, as they are generally tried and tested, but there is a question in regard to compression stockings, which I think have very little evidence of protection. There's really little evidence in the literature that supports their use, and the main problem is that because they've become standard or established practice, to do away with them sets a medical legal precedent, and we need to have more information to exclude them, it seems, rather than to commit to them. If they can be excluded, and they certainly won't stop pulmonary embolus from the popliteal vein compression problem, as this begins and progresses above the top of the below knee stockings. So for this I can completely agree that the stockings are not necessary, but with full assessment and adequately planned trials there should be considerable savings in the discarding of the compression socks. I think they've been used to treat a ghost. We are responsible for advising the positions that patients are nursed in. We are responsible for implying that it is safe to rest in the sitting or recumbent position with the legs elevated. So we are responsible for allowing lives to be threatened once we understand this problem. Going back to the first graphic, the first photo shows a floating clot in the superficial femoral vein, and this is from my training years at the Prince of Wales Hospital in Sydney many, many years ago. At the time we had no idea why, But the popliteal vein occlusion problem easily explains this event that occurred in a young woman who was recovering after an appendicectomy. This also explains why popliteal vein occlusion can easily lead to a pulmonary embolus without having any signs in the leg. General consensus still believes that there can be no impedance to flow in the straight leg, and because of this, billions of dollars have been wasted, and at present all the international guidelines to examine for DVT and pulmonary embolus with duplex have not resulted in any improvement in understanding of the cause. All the international guidelines are wrong, as they don't examine the popliteal vein region in the extended position, and they certainly don't examine the area with the patient sitting with the leg out extended, which is the position that we have evidence to believe is the major cause of deep vein thrombosis and all the other complications. You hopefully can now understand my reasons for trying to get acceptance for the idea that idiopathic should be changed to iatrogenic until medicine as a whole understands this proposition and changes our attitude to managing our patients. So where do we go from here? I think it's quite obvious that if we don't make significant changes in our management, we will eventually be forced to by medico-legal forces, and in that case it may be that we will be individually challenged if we haven't changed our management of our patients before they have a significant event. It's going to be important that there is training from the universities and the TAFE colleges for new students, both medical and nursing. It's important that already at the clinical level, training is developed to bring about a change in management immediately. The government, our colleges, and those bodies responsible for providing guidelines on the management of DVT should all support further investigation and studies to confirm this data and help promulgate the information. In 1843, Oliver Wendell Holmes published his ideas about the cause of puerperal fever, and it took 40 years for his ideas to be accepted. We can't really wait another 40 years before action is taken in regard to this. In the 21st year of the 21st century, we are in an age of great scientific discovery, exploring space and diving deep into the fundamental particles of the universe smashing around in the Hadron Collider. There are no complex maths in this current medical discovery. A very simple anatomical problem that is easily corrected with postural change, with the possibility of a major turnaround in death and morbidity. Creative medical thought outside the square of consensus has been blocked by intensive medico-legal considerations. The price of progress will continue to escalate because of this. The current consensus is that the straight leg cannot be associated with limited flow, and that is nonsense.